It's certainly not the patient who doesn't want to take medications. That may be in the future, but it is not the status right now. We usually look at patients who are resistant to usual blood pressure antihypertensive management, including 3 medications at optimally tolerated doses, including diuretic therapy, and most of the time thiazide diuretic. So those patients who are not responding, the patients who are responding to therapy but are having terrible side effects from their medications and prefer non-pharmacologic options in addition to medications they can tolerate. Basically, specifically patients who do not have renal artery stenosis, any abnormality with the renal artery itself and hypoperfusion of the kidneys were excluded from all the trials. Any patients with significant renal insufficiency were also excluded from the trials. So we're talking about a relatively compliant patient on medication, not responding or cannot tolerating medications. It is actually very good. Obviously, we know that 10 years ago, there was hype about renal denervation. Then the enthusiasm got a little dampened by the fact that the actual procedure, we learned from the procedure. So initially, the proximal renal arteries used to be denervated. And then with further research and cadaver studies and anatomical studies with imaging, advanced imaging studies, we noticed that the concentration of the nerves increases when we go relatively distal into the main renal artery. So including those distal renal segments with the denervation and including accessory renal arteries, which are very frequent. Almost 1/3 of patients have accessory renal arteries, which had not been addressed with the initial trials. So addressing those two issues improved the efficacy of renal denervation. And the most recent, obviously, trials showed that at least to 10 millimeters of mercury within 6 months after treatment, and some trials showed 20 millimeters of mercury, the reduction within 2 years after renal denervation. As far as safety, it is an extremely safe procedure. Thousands of patients were included in these trials. The potential for renal artery injury or other major renal or vascular complications is extremely low. So this is a kind of a done deal at this point from a safety standpoint. A very important role. So this is one of the main indications for renal denervation. In my personal experience, I find that especially patients who are very responsive to sympathetic nervous system inhibition, including beta blockers and clonidine, those are one of the patients that respond the most to renal denervation. Of course, this is anecdotal evidence, but it also makes sense from a pathophysiological standpoint, has not been demonstrated yet. But especially those patients who cannot tolerate beta blockers, clonidine, due to the extreme fatigue that they experience when they're young, or other side effects like erectile dysfunction, but of course, other medication categories. But it's important to be realistic with the patient. This is not going to replace chronic pharmacotherapy. As we said, 10 millimeters of mercury reduction in 6 months is not often enough. So patients have to understand that they will still be on medications, but at lower doses or less than 3 medications if they are on this regimen. It has significantly changed that. Obviously, we're still in the process of really awaiting approval from major insurers to make that available to most patients. But it definitely, the FDA approval, especially in the United States, having 2 FDA-approved technologies that will allow us to take care of these patients, has definitely entered the world of antihypertensive management. It is an option that we bring up whenever we face difficulties with treatment or with side effects. It's mostly the coverage. Obviously, these are expensive technologies, and we're going to have to wait until further data solidify the insurance and CMS coverage for specific patients. So that's the major limitation. Secondly, as we said, we don't want the patient to think that they're going to be off their medicines when after that procedure. So that expectation would have to be addressed ahead of time. And thirdly, of course, this is still an invasive procedure. It's not benign. These are patients with sometimes blood pressures of 180 to 200 millimeters of mercury systolic. We're sticking their femoral arteries, since this has not been a radial artery approach yet. The companies are working on that. But those are patients with very high blood pressure. We're getting access in their groin. There is potential still for bleeding if they remain hypertensive and their blood pressure is not well managed around the procedure, and like any invasive procedure.